on ICD-10 coding and medical documentation changes for pediatrics. We're going to go over how ICD-10 implementation will impact medical documentation and coding for various types of disease states within pediatric practice. So I am going to begin my presentation. Again, I'm with MTBC. I'm a coding consultant. I'm a certified coder, and I've been working with MTBC on and off for the past 3 years. Very involved now in helping them. As you know, they are an EMR, so helping them transition over from 9 to 10 within their electronic medical record system, and doing various education and documentation reviews for their various clients to see if their documentation will be specific enough for 10. In many cases it's not, and that's why physicians and coders alike need to be educated so we can make sure the revenue cycle remains intact beginning 10/1/14. So you're all in listen-only mode. If you need to ask a question or make a comment during this webinar, there's a question section right here, and you would type in your question at the end of the call. I'll be happy to answer all those questions. Okay. Otherwise, you can email the training@mtbc.com, and your answers will be addressed there. It's a little bit about MTBC. I'm not going to go into that now. The outline of this presentation is I'm going to go over a strategy on how to map your current ICD-9 codes to your 10 codes, what areas you need to review documentation, specifically, of course, laterality and specificity. Try saying that 100 times. The examples of some changes regarding laterality and specificity. And then specifically within pediatrics, I want to go over 3 categories that are going to change very much: diabetes, asthma, and ADHD. And of course, if you have any questions on specific disease states or screening codes within pediatrics, please feel free to ask them in the chat window, and I'll address them at the end. Speaking of screening status and follow-up codes, I will also give you some examples of those. Okay. So as far as a strategy, what we recommend you do is run a report within your practice management system to find your 50 most frequently used ICD-9 codes for claims within the last 6 months. Okay, and then you should use a tool to map those codes to the 10 codes. If you are an MTBC customer, we will do this free of charge if you are one of our billing clients. If not, there's some recommended tools out there. AAPC has a nice website, and the link is right down there, aapc.com/ICD-10/codes. And of course, ICD-10 data is one of my favorites, ICD-10data.com, which will show you. You type in a 9 code, it'll bring up all the potential 10 codes. Reverse, same thing. You could also put in a 10 code, it'll bring up all the 9 codes. Okay. I do also recommend you order an ICD-10 book for your practice, at least one. If you have many physicians or multiple coders, I would have 1 book per coder. Because even though you have the online tools, the book is what you need to actually look up on the index specific diagnoses. If you're still using a paper Superbill, and I hope you're not, but if you are, determine how many pages that new 10 Superbill is going to be from the mapped 10 codes. So your ICD-9 Superbill might have fit on 1 page, but your 10, it's going to be much more difficult to use a Superbill, any more than like 2 single-sided pages or 1 double-sided page. It's going to be a lot more, especially for specialties like orthopedics, where the changes are very high, and OBGYN. But even pediatrics, like leg pain alone, limb pain, leg and arm pain goes from 1 code to, I don't know, 30 codes, I believe, because now you're going to have upper arm pain left, upper arm pain right, and so forth. Forearm left, forearm right, lower leg left, upper leg left, and so forth, and bilateral for each one. So there'll be many more codes for certain 9 codes. MTBC does offer an electronic Superbill that you can accommodate as many 10 codes as the practice would like for charge capture, and that's what we recommend if you are an MTBC client. And if not, I recommend you do that within your own practice management system. Try to get this electronically. Because the 10 code is now going to be 3 to 7 characters in length as opposed to just the 3 to 5 and 9. And 10 CM codes have over 68,000 codes. 9 only had 14,000. So it's quite a bit different. The majority of the changes are due to laterality or being more specific. Some examples of the laterality where you can have a left, right, or bilateral would be conjunctivitis, otitis media, of course otitis externa as well, and humerus fracture. All the fractures are now going to be bilateral, of course if it's within the arm or leg or hand or foot. So sometimes there's one ICD-10 code for bilateral. Other times you'll have to code a left and a right if there is no bilateral option. It depends on the specific code. So some examples of specificity changes like fractures. Now when you have a fracture of, let's say, the humerus, you're going to have to say right or left. You're going to have to say whether it's non-displaced or displaced. And you're going to have to say where within the humerus. So in this case, the surgical neck. It's a two-part non-displaced fracture of the surgical neck of the left humerus. And then which encounter is it? Is it the initial encounter or a subsequent encounter? So in the old world, we had aftercare codes. Now we have the 7th character, this A, stands for initial encounter. And there are different 7th characters for subsequent encounters with delayed healings or with expected healings, okay? Non-union codes, malunion codes, all built into the 7th character. Okay, another common one, of course, and just an example on the fracture side. So for an initial, that would be seen as the initial treatment done in the ER, whereas the follow-up codes would be the subsequent encounters for the 7th character. Acute suppurative otitis media, now there's going to be codes with or without spontaneous rupture of the eardrum, and it's going to be recurrent or initial codes. So, for example, that H66004, they're all going to be in the H66 series, but again, you're going to have to specify with or without spontaneous rupture of eardrum, which ear, right, left, or bilateral, and whether it was the initial or recurrent, meaning somebody who's coming in with a subsequent episode of otitis media. Some more laterality examples. I did mention wind pain earlier. There's only one code in 9. In 10, there's more than 30 codes. And those are just some examples. They're all in the M79 series. Okay, so there's pain in left upper thigh, pain in right thigh, and so forth. For bilateral limb pain, you would need to code 2 codes. So somebody comes in with pain in the right forearm, pain in the left forearm, you'll have to code both, the 631 and 632. Conjunctivitis is another example where you'll have a code for right, left, or bilateral. Okay? And there is no code for unspecified eye. Okay? When there is a code for unspecified, you can use it, but you have to be careful. The payers are going to take advantage and deny claims for unspecified codes. And you'd have to read the medical policy of each specific payer. Okay? But when in doubt, please document laterality. Diabetes. You had 2 or 3 codes when you had a manifestation of diabetes in the past. You'd have, for example, type 2 diabetes or neuropathy, 256.0, and then 357.2 to specify that it was neuropathy. Well, in 10, there's just one code. You don't have to say there's no neurological manifestations code. It's just one code, and that's in the E10 and E11 series. The E11 series is type 2 diabetes. The E10 series is type 1. There are other series for diabetes induced by medication. I believe that's E12 or E13. Okay, so this example is one that had 3 codes in ICD-10. Diabetes with retinopathy with macular edema. You'd have to code for the retinopathy and macular edema. In 10, there's just one nice code. E10311. So in many ways, it's actually a lot easier in 10. And as you use 10 more, because I've been using it now for almost 2 years, being that I've been involved with the 10 transition, it makes much more sense to both the coder and the physician. Asthma, definitely going to be a big thing for physicians in terms of documentation. Many, many physicians already document this way, so it's not going to be a big deal. You now need to say whether the asthma is intermittent or persistent, okay? And if it is persistent, there are 3 levels, mild, moderate, or severe. So at the intermittent level, there's only the mild, and within persistent, again, it's mild, moderate, or severe. Just like in 9, there's either uncomplicated or status asthmaticus or acute exacerbation levels within the type of asthma. That hasn't changed from 9. So be specific depending on the presentation of the patient. These codes are the same as 9. There's exercise-induced and cough variant asthma. And all other terminology is the same, but there's one exception. There's this new category in 10. Allergic acute otitis media is now its own code, okay, in ICD-10. By the way, this should have been in the otitis media area. Okay, I just want to point that out, that this should have been on the other slide. ADD, with and without hyperactivity. ADD and ADHD, there was just 2 codes in 9. ADD without mention of hyperactivity and ADD with hyperactivity. Well, in 10, there's just ADHD, and then you have to specify whether it's predominantly inattentive or hyperactive or a combined type. So patient comes in and they basically have the hyperactive component, you would code the 91. If there's a mix, it's F92, and if it's predominantly just the inattentive component, it's 90. The adult residual or any other ADHD would fall under F98, and there is an unspecified code F90. I'm sorry, F99, that should say. Again, that's a typo, F90.9. But again, you have to check with your payers. But when in doubt, assume they may not pay for unspecified, and you have to code from one of the 4 more specific codes. Now I want to talk a little bit about screening and status codes. Big changes. Seems like a minor change, but it's actually quite different. You had just the 1 code in 9, V20.2, for any well-child exam from basically 0 to 18 years old. Well, now there's 2 codes. There's a code with and without abnormal findings. So if it's without abnormal findings, you'll just have the Z00.129 code. If it's with abnormal findings, you'll code the 121, but then you'd have additional codes for your abnormal findings, such as otitis media or a murmur or what have you, okay? So you'd have to make those the secondary codes. As far as which CPT to put on it, whether you're just going to put a preventive or also add the office visit, that kind of remains to be seen. But I think if it's just something that you found abnormally that you're not necessarily having a whole separate visit for, it's still going to be part of the physical preventive exam. But that doesn't remain to be seen. You have to check with your payers. I would bring this scenario up to all your payers. As far as the hearing screenings, very similar. There's a with and without abnormal findings. If there's with abnormal findings, you'll put that hearing abnormality on there. Well woman exam changes, very similar. There's a with abnormal and a without abnormal. There's also one for an eye screening as well that I didn't include. Okay, the same with and without abnormal findings. There are now codes for screening for diabetes codes. So if you're doing blood work, pediatric patient, you can use that code. And there's also a code for follow-up exam now after completed treatment for malignant neoplasm, such as chemo or radiation. That's a Z08 code. Well, I'm going to end on this note that everybody's going to be very happy about. There's a big one here for pediatrics. There's now only 1 code for vaccinations. So whether it's a flu shot or any of the childhood shots, there's now only 1 Z code as opposed to all those different V codes, and that's Z23. So that really will save you in terms of a Superbill or a charge capture, because you're only going to have the one, regardless of, again, whether it's flu, Hib, Hep B, what have you, all of them. Okay? So, questions, comments. I'm going to look to see. I see I have one question here. After seeing a newborn in the hospital by myself, subsequent initial office visit for newborn check, consider a recurrent visit. Seeing a newborn in the hospital, initial hospital visit, consider recurrent. If you saw the patient as a newborn, yeah, I mean, it depends what the diagnosis is, but yeah, I mean, if it's the otitis media, no, it will be the initial presentation. Recurrent would mean a whole separate episode months later. I'm not quite sure if that's your question, but if it's related to the otitis media question, then the recurrent means a completely different episode several weeks or months later, or even years. Okay? If that doesn't answer it, then please let me know by typing that in. Any other questions? See, we had about 16 people on the call, expecting more questions. Okay. Well, if you don't have any other questions, there is a response, just a routine newborn check. There is a Z code for a newborn check. So if we look that up, I'm going to look that up with you right here. I go to ICD10data.com, newborn screening, because I don't have all these memorized. And there's a neonatal screening. One of the codes is abnormal findings on a neonatal screening. So it's a P09 series. There's just one code for that. But I believe there's also a Z code for a completely normal one. So it really depends on what you found on the screening. It's going to be early on in the Z. There it is. There's a newborn under 8-day and a newborn 8 to 28-day code. Okay? It's the .110 and the .111. And as far as somebody asks for a copy of the slides, MTBC will be providing a copy to anyone who attended this seminar. So you will get a copy. Any other questions? Okay. I want to thank everybody for attending, and good luck with your ICD-10 transition. If you have any questions, please give MTBC a call if you're a customer. If not, you'd be a great addition to our team because we could help you very much in the ICD-10 transition. Thanks, and have a great day.